Okay, so moving on, we talked about anaphylaxis. Any questions about that specifically? All right, moving on. Next, our discussion of asthma. So, what is asthma? Yes, ma'am. Oh, all right. One of my favorite jokes. Again, please. Is anyone sensitive to language? It's just the one bad word. You are? Okay, leave the room and I'll. Okay, so anyway, there's this. This is actually from my hometown, kind of area where there's a lot of a lot of trailers and a lot of trucks and that sort of thing. And there was a trailer fire, and this trailer just went up. Some people thought it was meth related. Who can say? Or who can say? Anyway, though, there's one body there, and it was, I mean, just fried beyond recognition. They couldn't tell who this was, but the owner of the trailer was this guy named Joe Bob. And so the corpse was ferried over to the medical examiner, and they were trying to find some sort of identification, right? And of course, dental records didn't work because there were no teeth found. But the question was like, okay, well, we need to try to identify this guy. So they wanted to find his two best friends. So there's Jimbo and there's Curly. So they brought Jimbo and Curly over to the medical examiner's office. They wanted to bring them in one by one to see if they could identify the body, right? So anyway, Jimbo comes in first and say, do you think this looks like Joe Bob? And so he's looking at the body. And he goes, can you flip him over? And they're like, okay. And they flip him over. He's like, nope, that's not him. Definitely not him. And they're like, okay. So leaves the room. And Curly comes in afterwards and looking at the body and is like, can you identify this as Joe Bob? And he's like, I don't know, can you flip him over? Flip him over and he's like, nope, definitely not him. That's not him. And so the medical examiner goes out very confused and they're like, well, how can you tell it's not Joe Bob just by looking at his backside? And they're like, oh, because he doesn't have two assholes. And he's like, what are you talking about? He's like, yeah, they say every time Joe Bob come walking into town with us, they say, hey, look, there's Joe Bob with those two assholes. That's one of my favorite jokes. So. If that's one that gets me fired, then I'll do it. I'm okay with that. Yeah. Anyway, all right, so asthma. This is a very important concept to me. It's something I am personally afflicted with. I was a terribly controlled asthmatic child growing up. I had my inhaler with me everywhere I went. Fortunately now I'm very well controlled at this point, which is very good. But anyway, so let's talk about this because it's very, very important. It can be potentially deadly in some cases. What is asthma though? How do you characterize it? Kind of like bronchial smooth muscle hyperreactivity, right? So again, it's similar pathophysiology to the anaphylaxis, just not so widespread. Kind of relegated strictly to the bronchial smooth muscles. It's hyperactivity that they are having this bronchoconstriction. It's impairing, oxygenation. So again, how are we going to deal with that? What do you think is the main, type of treatment we're going to be shooting for these patients? Beta2 agonists, right? What are beta2 agonists going to do for us? It's going to cause bronchodilation, smooth muscle relaxation. Good. What else can we do? Because steroids, right? It's an allergic reaction. We can give them steroids. It's hypersensitivity. So if we dealt with that inflammation, that presumably would deal with the same issues here, right? We're going to be focusing on a lot of these same pathways as we go forward, and we're going to see how a lot of these same concepts that we use in anaphylaxis are also going to be applying here as well. See how those work. Anyway, but again, it's going to be this inflammation. It's going to be leading to both airway hyperresponsiveness. We're going to be seeing that, that smooth muscle constriction here, but also the airway obstruction. Why is that occurring? A lot of mucus production is going to be happening here as well, right? So again, the bronchial smooth muscle is going to be tightening up, but then you're also producing these new secretions and whatnot. And again, what kind of receptors do you think are involved with those secretions? Remember the mnemonic where you had like a lot of secretions? The dumbbells, good. The dumbbells was referring to muscarinic receptors, right? So again, we're going to see muscarinic receptors are going to be playing a role here as well, right? So we have kind of both sides of the autonomic nervous system playing a role here. And again, that's where we get our clinical symptoms: cough, wheezing, sputum production, all these different things we're going to be seeing associated with. Again, if you imagine these mast cells, as they degranulate, they're going to be activated by IgE. Is we're going to see things like histamine being released here, which we know is important for inflammation. We're going to see things like heparin, tumor necrosis factor. But the big things we're going to be focused on here as well are going to be things like leukotrienes. Those are going to be probably the biggest sort of aspect here we're going to focus on from an asthma standpoint. But obviously, if we can do things like steroids, that would certainly help from kind of the top down from an inflammation standpoint. And so that's where those are going to be used for more of a kind of better control, especially for really severe asthma exacerbations. But we'll also have some other ways we can treat that kind of down the line additionally. Again, typically when you see an asthma exacerbation occur early on, you have this kind of early reaction where the kind of initial clinical manifestations will kind of present themselves, but you also have the kind of a more long-term sort of late reaction. And in fact, if you don't have kind of good control of that inflammation many hours later, that's oftentimes where patients who die from an asthma attack die from that phase there, where they're not being appropriately managed, and then kind of normal standard therapy may be less kind of effective at that point. So again, we're going to see, especially with asthma exacerbations, kind of the initial early treatment for it, and then how do we kind of tamp down that inflammation kind of going forward. And so that's where you see things like those methylprednisolone dose packs and et cetera, 5 days worth of steroids. That's where that's going to be useful for treating that kind of late reaction you'll see there. Again, looking at when the allergen kind of activates the cytokine productions, we're going to see these mast cells starting to degranulate, and this is where you can see the kind of the smooth muscle of the bronchioles are going to start to get more constricted. Here's kind of what the normal would look like, and you also are going to see a lot of mucus plugs forming here, kind of forming these kind of little micro obstructions to kind of prevent that oxygenation from occurring. So another big thing to note here is this arachidonic acid pathway. Now the one we're most familiar with is going to be what? Cyclooxygenase, right? So we had our cyclooxygenase pathway producing things like prostaglandins. Obviously, that's very important for inflammation, for pain, for antipyretic, things like that. But you also have this lipoxygenase pathway we've not really alluded to too frequently now, but this is a big one for asthma because, again, we're going to be producing things like LTD4 and LTE4, which are going to be responsible for causing some of that bronchial smooth muscle constriction, causing some of that airway hyperresponsiveness. And so one of the things, has anyone ever heard of like aspirin-induced bronchospasm? Or like an aspirin allergy where it induces an asthma attack? Sometimes like NSAIDs can do this as well. This is a process which kind of makes sense based off the mechanism here. So imagine I had this arachidonic acid pathway producing more arachidonic acid. What would happen if I kind of cut off the cyclooxygenase activity there? What would happen to all that arachidonic acid? It's going to get shunted over to the other pathway. And so if you had someone who had aspirin-induced bronchospasm, what's happening is you have aspirin around, or an NSAID, blocking the cyclooxygenase, shunting all of that arachidonic acid specifically into the leukotriene pathway via 5-lipoxygenase, and guess what? All these leukotrienes are now being formed, which weren't there before. That's how you induce that asthma attack. So if you ever hear that, that's specifically what it's referring to. It's not necessarily they have a true aspirin allergy. It's just that they have this predisposition to produce things like leukotrienes like that. But again, this kind of describes what we've already been going over so far. But again, it's an IgE-mediated sort of reaction here, which is going to be important when we're looking at some of our therapies in a few. And again, the early phase is going to be causing that acute bronchoconstriction. You're having a lot of vascular leakage as well, so it gets kind of edematous. Seeing that mucus production happening there, and then you'll have that more kind of prolonged phase where you see much more kind of pronounced mucus production due to IgE stimulation. So, what are some things that can induce asthma attacks? Exercise, for sure. You can have exercise-induced asthma. What else? Allergens. Animals can act as allergens, right? Chemical irritation can be one thing. Cold air can do it potentially. Again, the whole airway is going to be very hyper responsive to some of these things. Some people have certain triggers. So, for instance, if you were to throw a cat at me, I would have very severe asthma attack because again, those allergens just happen to be what I'm hypersensitive to. I would recommend not throwing cats at me if at all possible. But anywho, so again, one of the ways we can actually diagnose them with asthma is to see if they are hyperresponsive. And so something we can actually give is something called methacholine, which kind of looks similar to what neurotransmitter? Acetylcholine. Actually activates the muscarinic receptors. So if you were to give someone a dose of methacholine, we do this very frequently over at Nemours when we're diagnosing patients with asthma. We'll give them methacholine, a challenge of it. They'll breathe it in, and if they have this hyperresponsiveness, and how would you measure the airway resistance? FEV1 is going to be the big thing you're going to be measuring, right? So if you see a decrease in FEV1, you're going to find, yes, they are hyper responsive to this. And then, of course, you don't want to just induce an asthma attack on someone and leave them there, right? You probably want to treat them afterwards. So in those cases, we end up giving them something like albuterol to help reverse that. But then we have a more easily diagnosed sort of thing there where we say, yes, we have documented decreases in things like their FEV1. We know they're hyper responsive. So, again, the bronchoconstriction here is going to be mediated through several different pathways. You're going to find that we can use several different drugs with different mechanisms in order to treat this. You can see things like, certainly acetylcholine is going to be important here through muscarinic receptors. Certainly things like, blocking the beta-2 receptors can certainly lead to things like bronchoconstriction, which is why we like cardioselective beta blockers for patients with asthma. Even things like substance P, which is responsible for a lot of things like pain transmission, things like that can also stimulate smooth muscle contraction. Anyone ever heard of someone like eating something really spicy or inhaling something spicy and having bronchoconstriction related to that? that can be something you can see. Some people are really responsive to that because that can trigger off substance P release due to some of the capsaicin you can find like in spicy peppers and things like that. But just know that's why we're going to be shooting for different drugs with different mechanisms here. So the therapeutic approaches we're shooting for here are going to be one to reverse the bronchospasm. You see some of the drugs we're going to use for that. We can remove the trigger of the antigen. This is where we can try to use things like mast cell stabilizers, like we saw with things like ocular allergies and nasal allergies. These are going to be used less commonly, as you'll see. And then the other big ones we're going to use are going to be to help control inflammation. This is where we have steroids, have things like lipoxygenase inhibitors that would produce less leukotrienes if you were to inhibit that. So you'll see there's lots of different options we have here. So as I mentioned, that methacholine test we can do, we can try to induce an asthma attack in those patients. If we see, say, like a 20% reduction FEV1, guess what? You're hyper-responsive. We think you have asthma. So a lot of times though, you're going to be doing it just based off symptomatology here, right? So again, you're looking at things like, well, how often are they having symptoms? Are they waking up in the middle of the night? How often are they using their inhalers here? Now, again, what's a common thing you might think? Say you have a patient you're treating for asthma, you give them a short-acting beta agonist like albuterol. What's a good way to tell if they're really well controlled with their asthma or not? So say they come back and the pharmacy's calling you up and say, hey, the patient says they're out of refills for the albuterol. What do you think that means? Probably means they're not all that well controlled. They're having to use it so much, they're actually running out early. They're not able to get their refills. They ran out of prescription, those refills on there. That's probably a good sign they're not really either being that compliant with some of their controller medication, or they're just not that well controlled. So things like how often they're using their beta-2 agonists, the sign that I had to carry mine with me, probably from the tender ages of say 6 to 24, was probably a good sign that I was not all that well controlled as a child from my asthma standpoint. Notice my mom and dad are both nurses and they still couldn't get things under control. So oftentimes healthcare providers are not the best healthcare providers for their family. Anywho, I have wonderful parents though, trust me. Anywho, so again, you're looking at things like how it's interfering with their activities of daily living. Looking at, obviously, at PFTs are also going to be a big thing you're looking at as well. That will help you kind of classify kind of where they're at and will dictate what sort of therapy you're going to need to help manage those patients there. And again, big things we like to do are try to reduce the hyperresponsiveness. So you're going to see that we both will have things that are working in the short term, things that are good for acute exacerbations, and things that are going to be better for long-term control. So when we say controller medications, that's what we're going to be referring to from that standpoint. Okay, this is where we're going to see things that are going to be anti-inflammatory agents, right? Like inhaled corticosteroids we're going to talk about. And then obviously we wanted to try to prevent or reverse an acute bronchospasm. That's where fast-acting medications like beta-2 agonists are going to be good for. And then also if we can avoid allergens, if I can avoid going around cats or dogs, that can be something that can help me out, right? So, and again, breaking these down into two big categories. The quick relief medications are where you're going to see your beta-2 agonists, the short-acting beta-2 agonists. If you ever see SABA, that's what that's referring to, short-acting beta-2 agonists, anticholinergics, and then systemic corticosteroids. And we have our long-term controller medications. So we're going to have long-acting beta agonists. So you ever see LABA, that's what I'm just referring to, inhaled corticosteroids, Leukotriene Modifiers, mast cell stabilizers. We have a whole list of things we're going to go over. They're going to be good for controlling asthma medications, right? So again, oftentimes what you'll find with a really uncontrolled asthmatic patient is you'll write them a prescription for a controller medication and a short-acting beta-2 agonist, and then all of a sudden the pharmacist's calling you back saying, hey, they need a refill on their albuterol. You say, oh, what about the other med? I was like, oh, they either didn't fill it or they filled it and they never came back for a refill, showing you that what? Not being very compliant with it, right? So again, compliance is a huge thing with this. A lot of these medications do not work if you're not going to use them, right? You got to use them very consistently. So what oftentimes happens with these patients, not that I would know because I would be my own test case here, but you feel better, you stop having the intermittent asthma attacks, and then you guess what? Well, I don't need the controller medication anymore, and you go off of it. You stop using it. Guess what? You may still actually need to be on that because, again, if you're still using that short-acting beta agonist consistently, that's not a good thing. Ideally, you'd like to get to where they never need their albuterol inhaler. They'd just be on the controller medications, right? They only need it kind of on a rare as-needed basis. But you find that a lot of these patients will not be compliant with the controller medications, thus they're going to use that short-acting beta-2 agonist all the time, right? So anyway, so the way the beta-2 agonists are going to work is specifically to activate those receptors that increase cyclic AMP, and then they're going to cause smooth muscle airway relaxation there, okay? These work very quickly, usually about 4 to 6 hours or so they're going to be working there. And I'll talk about the different dosage forms a little bit later on. The long-acting ones typically work for 12 hours or longer, so usually they'll have once or twice daily dosing. They're going to use very consistently, right? Again, with the short-acting beta agonists, am I going to schedule that necessarily? Probably not. It's going to be more on a PRN basis. So I might say every 4 to 6 hours as needed for coughing, wheezing, whatever the case may be, right? Versus the long-acting drugs, those are going to be twice a day, just scheduled, okay? Now again, what side effects you might expect to see from this? Why do you think you would see increased heart rate? Maybe a little bit due to some vasodilation if you had some smooth muscle effects on the vasculature, but more frequently what you end up seeing is something that says I'm only a beta-2 agonist. Is it 100% only going to be selective for beta-2? There's always going to be some bleed over, right? So again, you can find that, especially with high doses, you're going to find that by activating, having high doses around, they'll activate beta-1 as well. And you can see that increase in heart rate. Okay, so it's a very common side effect with the albuterol, especially the bigger doses they're going to get. So if you ever put a patient like on a big nebulizer and they're inhaling just a ton of albuterol, they get very tachycardic due to that effect of that bleed over effect affecting beta-1 as well. Okay, and then tremor as well. If you're activating beta-2 receptors on the skeletal muscle, they get very tremulous due to that. So just a picture kind of showing you what's going on here, where you have a beta-2 agonist coming in, activating cyclic AMP, and that's going to help to inhibit this effect of keeping the actin and the myosin from coming together, right? So that can be a good way to help relax that. And then notice here as well, there's going to be some calcium involved here. This is going to be important when we talk about magnesium a little bit later, kind of similar to what I talked about magnesium being good for torsades as a natural calcium channel blocker. This is going to be one of those drugs that you can use as well for asthma. Anyway, the beta-2 agonist we're going to use most commonly is going to be albuterol. Several different brand names. There's ProAir, there's Ventolin. There's also one called levoalbuterol. What do you think the relationship is between those two? Yeah, levoalbuterol is going to be one of the enantiomers of the racemic mixture albuterol. So there's probably a dextroalbuterol as well that does not get used clinically. I will tell you that most patients do not need Xopenex necessarily. Some people will claim that it has fewer side effects. I think it's mostly due to the dose that patients are receiving. Typically, if you decrease your albuterol dose, you can get rid of some of those side effects. But some patients do require or will insist that they need their Xopenex. But it's usually more expensive. Most of the time, patients can will be fine just on albuterol by itself. Now, those are good for short-acting, quick asthma exacerbations. The long-acting forms we see here, things like formoterol and salmeterol, these you do not want to use them by themselves for asthma. Okay, you typically want to use these in combination with something else, namely an inhaled corticosteroid, which I'll show you in a second, because they actually have some studies showing that if you use a long-acting beta agonist by itself for asthma, it actually increases mortality. Okay, don't really know why, but that's what we kind of observed in some studies. Now, again, when you reverse that bronchoconstriction, some of the ancillary effects I mentioned, the tachycardia, maybe a little bit of hypotension. Anyone know what beta-2 agonism does to potassium levels? Actually, you can shift it intracellularly. You can actually find hypokalemia can develop from this, especially at really high doses around. And actually, this can be a short-term treatment for hyperkalemia. So if you ever see this in the ER, patient doesn't have IV access yet, you can actually give beta-2 agonists like albuterol and shift that potassium intracellularly. But again, these are the main side effects you run into. Maybe some dizziness, some insomnia, tremors. All that has to do with that beta-2 agonism effect, kind of being a stimulant there. Now, as far as controller medications go, these should be one of the first-line meds you're going to be putting these patients on. This includes things like beclomethasone, fluticasone, budesonide. Where have we seen these before? Yeah, we use them intranasally to control rhinosinusitis, right? So this is one of those things where the dosage form is really dependent on this. You could use these intranasally. We also have inhaled forms as well. Notice usually the brand name is going to have something in the name that's going to kind of clue you in as to what it's being used for. So for instance, Pulmicort, you think Pulmonology. Things like Flovent, you think vent, ventilation. So sometimes they'll kind of clue you in from that standpoint. Because what did I mention about these medications? Just from a dosage form standpoint and errors. They're easy to mix up, right? So again, you can get the nasal one mixed up with the inhaled one, and again, you want to be careful with that. So sometimes having the brand name there can be somewhat useful. It seems silly, but silly mistakes like that happen all the time in medicine, as you'll find out. Now, their main mechanism obviously is going to be working at the site of the nucleus to decrease inflammation, kind of from the top down. But you need to have these on all the time. They need to be on them consistently, and they do not kick in very quickly. You need to give them a couple of weeks before they really start to kind of kick in, up to 8 weeks before they have kind of full effects. Okay, so that means that patients, even though they're starting to feel a little better, as soon as they go off the meds, guess what? Symptoms are probably going to come back to right where they were before, right? Assuming everything else stays the same. But they need to be on consistently. So the benefit of using inhaled corticosteroids is what over, say, systemic steroids? A whole lot less systemic side effects, right? I don't have to worry about hyperglycemia. I don't have to worry about things like infection necessarily. However, you do have to worry a little bit about infection because one of the things you can find is that when you inhale these medications, does all of it just magically find its way into your lungs? No, someone's going to hit the back of your throat, someone's going to go down to the GI tract. Again, this is kind of taking, so to speak, a shotgun approach where you're just inhaling the medication and hopefully some of it gets into the lungs. We'll talk about technique a little bit later and how that can be pretty variable, but it's one of those things where if you have that drug kind of hitting the back of the throat, you get a local sort of immunosuppression, and that's where you can see thrush, right? You see oral candidiasis develop from that. So you always want to recommend to patients when they're using these drugs, wash their mouth out after they inhale the drug. That way you can kind of wash away any fungus that might be there, and hopefully wash away any drug that's there, and hopefully not develop that thrush infection. Okay. Other concerns, really high doses, you do worry about, especially in kids that may have some systemic absorption. There's some concern with suppressing growth, one thing to worry about. And then especially for those smaller patients on really big doses, they'd be more at risk for developing systemic immune inhibition. But for the most part, these drugs are very well tolerated, very effective at controlling these asthmatic symptoms. Most of the time, they're going to, especially for asthma, come in combination. So if you ever see like Symbicort, it's just formoterol plus budesonide. So the long-acting beta agonist plus an inhaled corticosteroid. So what's nice about these is kind of initially on, you're going to find the long-acting beta agonist will kind of kick in the first early couple of days or so. And then by the time you're on it for a couple of weeks, you're going to find the steroids going to kick in, and they can be very, very powerful controller medications, right? A lot of these are still brand name. A lot of them are still expensive. So it could be one drawback to that. But again, very good from a controller standpoint, right? So Meteorol, fluticasone, right? Long-acting beta agonist plus an inhaled corticosteroid. So moving on from there, some other controller medications we have. We have things like Leukotriene Modifiers. So these are going to be drugs that are actually going to block the LTD4 receptor and block any of those leukotrienes you might be forming through that lipoxygenase pathways and prevent them from activating those receptors there. So again, this is good. Montelukast or Singulair is a good one from this category, probably used most commonly out of this bunch. Not the most powerful controller medications, but very limited side effects for the most part. Very, very well tolerated by most patients. This can actually be good though in aspirin-induced asthma. And why do you think that is? Remember with aspirin-induced asthma, we're shunting all the arachidonic acid into the leukotriene pathway. So if I'm producing more of those, I can block up the receptors, and they're not going to be really kicking in at all, right? So maybe if I had a patient, say for instance, someone with like cardiovascular disease, they need to be on aspirin, but they're at risk for that bronchospasm. Maybe there could be a role for something like Singulair to play, where it can maybe block that, and they can still be on their aspirin, right? So the antiplatelet effects. You can't imagine that coming up too often, but it could be something you may think about. Another one, this is not very seldomly used, called Xyluten or Zyflo. This actually inhibits lipoxygenase itself. So instead of actually producing the leukotrienes and having to block those receptors, you just don't produce the leukotrienes in the first place. However, some issues with this, things like inhibiting CYP3A4, flu-like symptoms, it's not used too commonly. But just another drug we have that could affect that leukotriene pathway there. You can imagine here, either we could attack the pathway here just by blocking the lipoxygenase, or more commonly, and I see a lot of kids, especially on this medication, be on Singulair, would actually block the LTE or LTD4 receptor, prevent it from ever activating it. Again, from a side effect standpoint, again, a lot of things are listed, but it's very rare, very well tolerated for the most part from what we see. Some people complain of tiredness. I think some people are a little bit more sensitive to this than others. From a mechanistic standpoint, I don't really know why, but some people just get really tired when they're on these leukotriene antagonists. Okay. Again, other things not used too commonly, we can try to stabilize the mast cells. This is where something like cromolyn or netocromol could be happening here. But remember what we said about using a mast cell stabilizer. When is it important to use it? Before the insult occurs, right? So again, before the allergen is actually come into play here. So again, one of those things you'd have to take consistently in order to make sure you don't have these asthmatic symptoms popping up, right? So again, just like any of the controller medications, you need to take them consistently, otherwise they're not going to be all that effective there. Again, they do take a few weeks to kick in as well. So again, you're not going to really see those immediate effects like you would to say something like a long-acting beta agonist, but they can be used if they were maybe intolerant to a lot of the other medications there. Okay. Again, side effects, nothing too significant to write home about. Again, pretty well tolerated, but also pretty wimpy as far as efficaciousness goes compared to something like an inhaled corticosteroid. Okay, so another one, this is actually a big one we see used in patients who are really intolerant or not well controlled on things like inhaled corticosteroids. Maybe you've maxed out those doses, they're on a long-acting beta agonist, they're still not really well controlled. This is where we have a drug called omalizumab or Xolair that can be used as a very good controller medication. It's also going to be associated with a lot of expense, a lot of side effects, but can be very good to help control really unmanageable asthmatic symptoms. So again, just off the name, it's Monoclonal antibody. Good. This is actually an IgE that is designed to target other IgE, right? So it's actually designed to go and grab up the IgE that will normally go and activate those mast cells. So if you get rid of all that IgE, guess what? It's not there and present to actually activate and degranulate the mast cells. It can be very effective to control that and prevent the degranulation from in the first place. Okay, so very effective. However, it's going to be an injection. You have to go into the clinic every 2 to 4 weeks or so to have your injections done. And again, anytime you give a monoclonal antibody, you worry about anaphylaxis, right? So again, it's one of the things you have to monitor them for a short period of time to make sure they don't have a reaction to it. So you have to worry about that. There's also some concern for secondary malignancies. I don't know if that's going to bear out to be anything notable in the long term, but just be aware that could be a concern, something you want to talk to your patient about. Again, anaphylaxis is pretty rare for the most part, but again, as patients come in, they get repeated doses and may develop sensitization over time. And so again, it could be something where you see a reaction occurring there. Obviously, it's an injectable product, so we'll see some bruising and some injection site pain associated with that. Okay, methylxanthines. This is kind of a broad category covering a couple of drugs. Some of you might be abusing a methylxanthine right now, and we know what that might be. I hope no one says like meth or something. That would be quite telling. Caffeine, right? Somebody's consuming caffeine in this room, if I had to guess. Everyone's water drinkers, but so methylxanthines include things like theophylline. They also include things like theobromine. Where do you find theobromine? Chocolate. That's why you can't give it to dogs. But it also includes caffeine. So again, I'm a avid methylxanthine abuser. I'm proud to admit. Actually, it's probably good for my asthma, as the case may be. Maybe that's why I drank so much soda growing up. Who knows? Could have explained a lot of things in my life. Who could say? Anywho, these are not going to be used quite as frequently from a control sort of standpoint. Again, this is a very old school set of drugs, right? These drugs have been around forever. A lot of side effects associated with them. However, you still may see them either being used in patients who are quite old. Usually I see these like in like little ladies coming from the nursing home who are like 80 or 90, and their doctors are prescribing are probably about 110. And they've just been on it for decades, and it's like, well, not broke, so why fix it, right? And so you see occasionally there, or you may see this being used in very, very severe status asthmaticus, right? We'll talk more about that a little bit later. But basically, you either have theophylline, which is a typical oral form you see patients may be taking. You may see this a little bit more frequently in COPD, but not used too commonly. And then the IV form is aminophylline. So you ever see that? That's what that's referring to there. The reason why we don't like it, very narrow therapeutic index, which means what do you have to do as far as monitoring goes? Blood levels. You got to monitor blood levels with these medications here. And again, associated with things like arrhythmias, convulsions, all kinds of bad things if you're not watching the levels and keeping those under control. Again, not as effective as something like an inhaled corticosteroid. You know, a lot of side effects. Again, we like to hold off on this if possible. Again, theophylline may be used in COPD a little bit, but it just depends on the patient, what they're responding to. Several different mechanisms associated with this. We have things like inhibition of phosphodiesterase 4 and 5, so you end up seeing some bronchodilation, smooth muscle dilation due to that. It's also an adenosine receptor antagonist, so this is actually block the effects of adenosine, which is why you can see how it would cause things like tachyarrhythmias, right? Earlier we said adenosine does what to the heart? Shuts it down, right? So if you block that effect, perhaps you could see increases in effect, right? So tachyarrhythmias can develop from that. And there's also some anti-inflammatory responses from there. But again, old school drug, we used it for a long time because that's all we had. Nowadays, we have a lot better medication. Again, you know, will cause a lot of CNS stimulation leading to seizures as your levels get higher. You know, cardiac stimulant causes arrhythmias for sure. I'll never forget, I had this one patient who came in. Again, she was one of those like nursing home patients who had been on it for like 30, 40 years. And when do you think the last time her dose was adjusted? 30 or 40 years ago, and so no one ever monitored the fact that her renal function was declining that entire time. And so she came in, levels are super high. She ended up developing into status epilepticus, and unfortunately ended up dying from that because you just could not get the seizures under control in those cases there. So you got to be really careful with this one if you ever seen anyone on it. Monitor the renal function for sure. You can see here how 5 to 20 could be a therapeutic level, but even here at the high end of that therapeutic level, you can start to see some of these toxic effects here. So very nasty drug from that standpoint. And then another class here we have are the anticholinergics. So again, how do you think these are going to work? Going to block muscarinic receptors here, right? So we saw that was important for causing things like bronchial secretions and bronchial smooth muscle constriction. So blocking that, you're going to see some dilation that can occur with this and some drawing of the respiratory tract. Now, two big ones in this category. We have a short-acting one called ipratropium or Atrovent. Now, if you're looking at treating an acute asthma exacerbation, most of the time albuterol will be given by itself. Occasionally, if you have someone who's, say, presenting with more severe symptoms, they may give a combination of ipratropium and albuterol. So if you ever hear someone talk about a duo-neb, that's what they're talking about, is a combination of albuterol plus ipratropium. The long-acting form is going to be used for COPD only, and that's called tiotropium, and that's Spiriva. Okay. Again, that one's going to be working for 24 hours or so, a very good long-acting sort of medication there. Now again, remember anticholinergic side effects. You shouldn't see a lot of these when you're giving these inhaled, but again, if you had very big doses, maybe in some younger patients, this is where you could run into this. Remember the mnemonic, that is the hatter, dry as a bone, all this good stuff, right? We've covered that, so you guys know that. You can reference this slide again. Now again, what can you do? Say all those medications are not working. What do we do to control that inflammation? Well, we can go even kind of bigger guns here, and especially for an acute exacerbation, this is where oral systemic corticosteroids are going to be used here. Now, you can still use some IV steroids depending on how severe the asthma exacerbation is, but these are good for what we call kind of pulse dose therapy. You're only going to be giving it for about 5 days or so, or kind of getting the inflammation under control, and then hopefully weaning them back down to whatever their controller medication is. Okay. So if they're coming to the ER for asthma exacerbation and getting admitted, they're probably going to be put on some systemic corticosteroids, usually 5 days or so, and then they'll wean them back over to their controller medications. Okay. Again, these would be very good for decreasing that inflammation, especially the late-term sort of inflammatory response we saw several hours after the initial insult. Here, we're going to be using things like prednisone or prednisolone orally. If they are more severe, we can use things like IV forms like methylprednisolone. Dexamethasone can be used parenterally as well. So there's lots of options over here. Okay. And remember the side effects we talked about. What do you see with these corticosteroids? Suppression of the immune system, maybe not as big a concern, maybe in the 5 days they're going to be on it or so, but if it's longer than that, I've seen some kids with such severe status asthmaticus that they're on it for 2 weeks, 3 weeks, that could be a concern for sure. What else? High blood sugar, so hyperglycemia is going to be a concern. Altered mental status changes, right, or mental status changes you can see with that. Some people would get really kind of cranky and aggressive when they're on some of these steroids. Anything else? Yeah, it's going to see some issues with bone deposition with that long term for sure. Yeah, edema can occur. You can get some weight gain associated with that. Maybe not good for CHF patients, right, because of the mineralocorticoid effects. Good. So again, we've covered these before. You kind of know what the general effects are going to be here. Now again, do I have to wean a patient off of the steroid if they're only on for 5 days or so? Now, if it's longer than a week, then you need to taper them off. So, for instance, we have a kid come in for severe status asthmaticus. They're going to the ICU. They may be put on, IV methylprednisolone, say Q6 hours, say for 2 weeks. That patient we absolutely do have to titrate off of, right? So maybe they go from Q6 to Q8 for a day or two, then they go to Q12, and they go to just daily, and then you have them off, right? Back on their controller meds. So that's one of those things, again, where you have to taper if it's more than a week there. Good thing, because we worry about the adrenal suppression.
Why is it that prednisone comes in the tapering pack with that being said?
That's more of a historical sort of carryover. I think for a long time people thought you had to taper steroids all the time. It doesn't matter how long you're on it for, you just had to taper them. So because of that, that's where the methylprednisolone dose pack came into play and became just the most popular. So it's one of those things where it's like, well, it doesn't hurt the patient to taper them, so we'll just leave it as is. And so I think a lot of, especially older providers, are just used to doing that. However, it's probably not necessary, right? And again, anytime you go and make a change to a formulation or how you're dosing a drug like that, like oftentimes you have to go back to the FDA and apply for changes and things like that. So it's like, we'll just leave it alone, So it's probably why it's still the most common way you're going to see that.
So would it be better to give like the full dose for the 5 days would be more effective?
I don't know that it'd be more effective necessarily, because again, you're probably getting close to the same total amount over that 5 days. They just kind of front loaded up front, and then as you taper down. But most commonly is what all of our providers are doing, at least from an ER standpoint, is that we'll send them home either on 5 days of prednisone. So for instance, again, don't know the dosing for my test, but I'm just kind of listing it here. We'll do like 1 mg per kilo of prednisone once daily for 5 days, right? And then they're done. They're off after that. Or sometimes what we'll do with dexamethasone, it's a longer acting medication. We'll do a 1 dose in the ER, and then we'll give them a dose for 36 hours later, and then it lasts basically for a 5-day period, and then they're off. They're done. So it just depends. I don't know that there's a good enough head-to-head trial to say, like, does this one tapering strategy work better? I think they probably both work equally as far as we know. So, and again, when you're dosing these patients with asthma, again, you're going to go kind of on a stepwise approach here, right? So this is one of those things where, you know, if they have intermittent symptoms, it only comes up every once in a while, maybe it's exercise induced, what are you going to give them? Short-acting beta agonists, right? That's probably all they need, right? So again, they're not having really persistent symptoms enough where they're going to require controller medication. You just give them a short-acting beta agonist, they're fine, right? However, they say, hey, I need another prescription. I ran out of my refills too soon, you know, something like that. That's where you need to consider, well, maybe they're having more persistent symptoms. This is where those diaries can be really useful to have an idea of just how often they're having attacks, how severe they are, et cetera. If they're waking up in the middle of the night. And so you just go in a stepwise approach, right? The initial thing you want to start with as far as controller meds go is going to be an inhaled corticosteroid. Again, if you can use the lowest dose possible, that's always going to be preferential. So start with a low dose, see how they tolerate it, right? If that doesn't work, maybe bump up the dose. Another thing you could do is potentially add on a long-acting beta agonist in addition to that inhaled corticosteroid, right? Either one of those would be fine at that point, and just see how they tolerate it, right? As you start to go up from there, that's when you have a lot more kind of play in what you might add on next. So, for instance, the leukotriene receptor antagonist like Singular might be okay. You know, if they're still kind of not really responding to many therapies at that point, that's where something like Xolair can be a big lifesaver. However, just remember that's expensive. It's got anaphylaxis as a big concern with that one. So it's not something we would take lightly. It's oftentimes when they're going to be, the pulmonologist is going to be the one recommending that at that point. So again, on a test question, if I came up and said, hey, patient comes in, you know, they're on, you know, the short-acting beta agonist, they had fluticasone inhaled, you know, what's they're, you know, still reporting frequent symptoms, what's the next best step in therapy? If I had Xolair on there, you'd be like, no, it's probably not good, right? Probably don't need it at that point. If I put on Theophylline, you'd be like, no, there's too many toxicities with that, probably don't want to do that. If I put on Spiriva, tiotropium, you'd be like, well, no, that's for COPD, I wouldn't do that. But then if I had fluticasone salmeterol, that would be a good option, right? That'd be the good next one to step up to, okay? So just having the idea how you'd kind of progress based on how they're responding to their current meds. Yes, sir.
Do Leukotriene Modifiers push the pathway down the cyclogenous?
Cyclogenase, yeah. So, clinically, we don't see that being an issue, though, although that would make sense.
Yeah.
But, you know, you can still, in the case of the Singular, even though you're blocking the receptor, you're not doing anything to the actual production of the leukotriene. So in that case, you really wouldn't shunt it over. I could see maybe like the Zyflo doing something like that, but I mean, clinically, we don't use it often enough to really for it to be a concern there. Yeah. Good question, though. You guys mind if I just go ahead and finish? I have 14 slides left. And I'm done with Palm, and then you're done, ready to go home? Yeah? Yay? Okay. So how do we actually get these medications into our patients? Again, technique is so important. You remember that like if I showed you that lady and he said, how to use your inhaler, and she spritz on her neck? Not great technique, right? So education is super, super important. If you can get your respiratory buddies to help out. So again, every asthmatic patient we have coming into Moore's in the ER, guess what? They're getting a respiratory therapist coming and talking to them about how they manage their asthma when they're leaving that hospital, okay? So again, very, very important to have those, the good interdisciplinary sort of care there. So anyone know what a spacer is? You guys are getting spacey right now, but it's a spacer. It's like a bong? Is that what it is? Like they're making bong motions. I don't. That looks like a trombone hand motion. Yep, a little bit. Yeah. So it's tubular in shape, absolutely, cylindrical. Some might say it's basically a chamber, right? So basically, it's something where you know, typically when you're administering something from a meter dose inhaler, if you ever see MDI, that's what it stands for, right? So basically, it's a canister with the drug in it, it has propellant, and you spray that. When you push it down, it actuates it, and then the spray comes out, right? You have to be pretty coordinated to make sure that you're breathing in that stuff in to get it into your lungs. If you don't have that, and who might have issues with that? Kids? Older patients, right? Especially if they have like osteoarthritis or rheumatoid or anything like that, is going to be impairing their dexterity. So because of that, we need something that can hold that medication and allow them to kind of breathe it in kind of asynchronously and when they're ready for it, essentially. So that's where you see a spacer or like a valve holding chamber. Basically, it's going to allow for that tube to hold the medication. It's designed to not allow the medication to stick to the sides, and then they'll breathe that in on their own. So they'll spray it, goes into the chamber. That can be very useful because it helps to make sure the patient's getting a bigger percentage of that dose rather than them, for instance, trying to squeeze it, but they were breathing out when they were squeezing it, and that didn't really work, or some other kind of odd sort of technique there, right? That could be one thing. What if they couldn't use an inhaler like that? What's another option? Someone say neb? Yeah, nebulizer, absolutely. So that's going to be something where you actually have a machine. What does a machine do? Yeah, it takes the medicine in a liquid form and it vibrates at a very high frequency to aerosolize it. So basically, you have this nice, it almost looks like a nice, like a smoke machine or something, where it's going to be aerosolizing the medications, where it'll have a mouthpiece that they can breathe it in, right? So the benefit with that is, one, you're getting a ton of drug in. So again, even if your technique is bad, all you're doing is passively breathing, you're going to get that drug in there. But what's one of the potential problems with that? Okay, so you need power, right? So again, if you didn't maybe have battery, a lot of them have battery packs, but again, if you didn't have access to power, that could be one thing. What else? So you're getting a huge dose is what the problem is, right? So again, typically, if you think about it, and just just for instance, a normal albuterol inhaler, that dose when you actuate that, it'll say 90 micrograms. Okay, when you have a nebulizer, the dose they're putting in there is 3 milligrams. So you get a huge amount of drug. They're not expected to breathe in all 3 milligrams, right? Because again, a lot of it's going to be just lost to the atmosphere. But they're still going to get a very big dose compared to what that inhaler would deliver. So that means they're more likely to get side effects, right? So I remember when I was a kid growing up, if I had like say a viral illness or something, it was really just kind of rocking my asthma, and I was just like not able. That inhaler just wasn't really doing it for me. I'd have to get my nebulizer out, right? My sister and brother would make fun of me mercilessly for it, but I get the nebulizer out, and of course it's super loud, and you just feel embarrassed just having to breathe this thing in. But I was so shaky and tremulous and palpitations afterwards because of all that albuterol I was breathing in. I could breathe fine, but I would just felt like miserable afterwards, right, because of those effects there. So good from the standpoint that they're definitely going to get the medication in. It's good, especially for kids, if you can just put a mask on them and they can just kind of breathe it in passively. That's what you'll see used a lot, especially on the inpatient side of things. Okay. So anyway, so a couple different ways you can actually get the stuff in there. The big thing though is just going to be the technique, especially if the patient's going to be kind of using just the meter dose inhaler by themselves. Okay. Basically, one of the big things you got to do is one, take the cap off, right? Just like if you're taking a picture, you want to take the cap off the camera, probably. Otherwise, you're not going to see much. You got to shake it up. What does that do? It's going to get the drug mixed in with the propellant and everything, so that way you're not just getting propellant shot out of the patient. It doesn't really do you a whole lot of good. Okay. And then you want to hold the medication, typically into the mouth. You can maybe hold like an inch away, but it's easier for most patients to hold it in their mouth. And then what you're going to do is you want them to breathe out slowly, kind of expend their breath, and then as they start to breathe in, let them breathe in for a second or so, and what you do is you kind of cause this laminar flow of air to occur, so that as they're breathing in, and then they can actuate the inhaler, and that's going to allow as much of the drug as possible to make it down to the lungs. I actually saw an interesting study one time where they had this like technetium traced albuterol that they were giving to patients, and they did a scan of the patient afterward to see where it actually ended up. And again, with poor technique, almost all of it was in the stomach or on the back of the throat, very little of it in the lungs, versus the good technique, you saw a ton of it light up right there in the lungs, right? So kind of an interesting, just goes to show you how technique makes all the difference here. But anyway, so again, they're going to start to breathe in, they'll actuate the inhaler, and that's going to allow the medication to flow in, nice laminar flow right down to the lungs, at least as much as we can there, okay? And again, you want to hold your breath as long as they can. Now, can all patients hold their breath for 10 seconds? Fortunately, no, but as long as they can, try to, right? And then typically, how do you dose a beta-2 agonist? How many puffs? Usually 2 puffs, right? 2 to 4 puffs, depending on symptomatology. But give a little bit of time between the puffs there, right? You don't want to just squeeze it twice. Because the first dose can get in there, loosen up the smooth muscle there, and then allow for the second dose to get in even deeper and be more effective. So usually wait 30 seconds, a minute between doses. And that's going to allow it to be that much more effective. That makes sense? Again, wash off the mouthpiece and stuff, because again, that can grow cooties if you don't keep it clean after a while. Again, you want to cause them to get an infection on top of their asthma symptoms. Okay. So again, that's mainly it for asthma. Remember what your controller medications are versus what your fast-acting medications are going to be, right? And be able to keep those in mind. Oftentimes, patients are going to need both. They at least need a short-acting, but they're probably going to need a long-acting controller medication in addition, okay? So status asthmaticus, what is that? Severe asthma attack, right? It's really unresponsive to most of your initial therapies. I just want to give you an idea of some of the additional things we might do for these patients. One thing we might do is continuous albuterol. We'll actually give them a nebulizer and just allow albuterol to be inhaled continuously as they go along. Patients can be on this for potentially days. Right? So get a lot of albuterol, just trying to get the smooth muscle as relaxed as it possibly can. May not always work, right? Obviously, IV steroids are going to be the cornerstone of therapy here, because that's going to deal with that inflammation again from the top down. Very, very important to get those on board. And then sometimes we'll actually use some additional meds as well. So for instance, if you ever see an asthmatic patient getting IV magnesium, that's what we're using it for, is actually is like almost like a calcium channel blocker to kind of smooth or relax that smooth muscle and allow for better oxygenation. So if you ever see that, that's what they're doing that for. And then potentially some of these patients have to become intubated to help control their airway. They're not oxygenating on their own. A lot of times what you find is those patients, those really severe asthmatics, they're using a lot of their accessory muscles to help kind of move air, and then what happens when they tire out? Yeah, they stop breathing, right? So again, that's one of those things where you may need to intubate some of those patients. And actually, for a sedative, we'll actually give a drug called ketamine. Have I mentioned ketamine before? I love ketamine. It's one of my favorite drugs. But I like it for asthma as well because it actually works almost like it increases catecholamine release. So it actually will cause increased release of norepinephrine. Epinephrine is really good for increasing blood pressure, but it will relax that smooth muscle and allow hopefully a little bit better oxygenation. So, and again, sometimes we use aminophylline, but it's usually kind of a last line sort of agent there. But just know we have a couple of different therapies we have available for something like status asthmaticus, so there's really severe sort of asthma attacks. Okay, and just real briefly, guess what? There's almost no new drugs with COPD. Really talk about anything new there. But again, COPD is one of those things where, again, what's the main cause for it? A lot to do with smoking, right? And again, typically you have a lot of reserve capacity in the lungs before you really see symptoms start to develop here. So again, you can have patients be asymptomatic for a long time, really, before you start to need to introduce medications here, right? The problem is any of this really kind of fully reversible? No, with asthmatic patients, they're hyper responsive, but ultimately they don't really have any structural issues going on. With these patients, you can't really reverse their problems unless you were to give them a lung transplant. So just to give you an idea of how the therapy changes a little bit here, here's in the case where we can actually use long-acting anticholinergics by themselves. In which case you would not use that for asthmatic patients. That's one of the big key differences here. But again, the biggest thing is going to be, obviously smoking cessation, hopefully prevent further progression if possible. And then again, they're still going to get a short-acting beta agonist, but this is where you can start to include long-acting bronchodilators. So this includes the long-acting beta agonists. This includes things like tiotropium, which is that long-acting anticholinergic. Those are going to be important there. And then as you go up, this is where you need to consider things like theophylline. And then notice here the corticosteroids are going to be kind of later on. Those are going to be not used until a little bit later on in the process, as opposed to some of these other agents used earlier on. And of course, oxygen obviously is going to be super important for them, but kind of outside of my purview. So I'm sure you'll learn about that elsewhere. And then the last thing we'll talk about real briefly is smoking cessation. So how effective are smoking cessation tactics? Not very, right? So again, just like with any addiction, it can be very difficult to kick the habit. What are some ways we can try to manage smoking addiction? Okay, so give them nicotine. Okay, well, they're addicted to nicotine. What is giving them nicotine going to do for us? Okay, so it reduces their urge to smoke, but they're still addicted to nicotine. What do you do with that? You wean them off, right? We're going to look at nicotine replacements, how wean them off of things. We also have a couple of other agents we can have that can help to kind of interrupt the addiction pathway, as we'll see here in just a few minutes. But again, you need to combine modalities here. You cannot just do it with nicotine replacements alone. You need things like CBT, cognitive behavioral therapy, to kind of help out and deal with some of these other issues. I know some patients who the physicality of smoking is so ingrained with them that is one of the big things that they kind of harp on. I remember I had this one a teacher when I was taking Gen Chem many moons ago in undergrad, and his name was Dr. Healy, and I'm pretty sure helium was named after him because I think he was 9,000 years old. But he held the chalk in his hand. He had this like resting tremor, but he held it like a cigarette, and I was just like, oh, the guy's probably been smoking like since like smoking was invented. But it's one of those things where it's just like the physicality of it. It can be sometimes something that people even ingrain themselves onto. But therapies we have here. Talk about one called Bupropion, some nicotine replacements, and then finally we have Chantix or Varenicline. So Bupropion, what do we normally use this for? Yeah, it's an antidepressant medication, right? We use it for anxiety, depression. This one works a little differently than a lot of your other depression medications. Usually depression meds work through serotonin. This is actually going to be working through blocking the reuptake of dopamine. Okay, and dopamine we know is important for what? Movement, yeah, absolutely. So again, if you don't have enough dopamine, you have Parkinson's. What else? Dopamine squirts, right? I'm glad someone remembered the dopamine squirts, right? What do I refer to the dopamine squirts, and what was that in reference to? Addiction, right? Remember when you eat a juicy hamburger, you shoot up heroin, you have sex, any of those are increasing the dopamine squirts, right? Your brain says, this is really good, I want more of that, let's have it all the time. Okay, for some people, some things are going to be more addictive than others. For some people, it's alcohol. For some people, it's going to be, drugs. For some people, it's going to be smoking. And so one of the things we can do is try to interrupt that dopamine pathway to try to reset it a little bit to try to prevent some of those cravings, right? Because again, it's that lack of dopamine your brain's kind of wanting to fix. It wants to get that dopamine high again. So by blocking the reuptake of dopamine, you kind of reset the levels a little bit to try to hopefully interrupt that mesolimbic pathway, that sort of that reward pathway there. And so what you're going to find is that you can actually use this for other things as well. There's actually a newer medication. It's actually a combination of this plus a drug called naltrexone being used for overeating disorders, right? So again, to interrupt binge eating disorders and things like that. Similar pathways here, just as like smoking. But anyway, so trying to kind of refix that, try to get the dopamine levels in control, and that hopefully will deal with some of the addiction process. Now, again, do you think a patient could continue to smoke? Like if they fell off the wagon and had to smoke, would that really significantly interact with this medication? Not really, right? It wouldn't be any problems. We're going to see that is going to be an issue though when we talk about nicotine replacements in a minute here. But be very careful in patients with history of seizure disorders. If they're on other antidepressants, this is not something you want to add on to that necessarily, because again, you're going to be seeing issues with interactions with their mechanisms as well. We'll cover that more in the psych meds next semester, but just kind of keep that in mind that you want to be very careful mixing this with anyone with other depression meds on board. Okay. Now, nicotine replacements, obviously the big thing is when people stop smoking nicotine, what happens? They have withdrawal symptoms, right? So again, they want to get that nicotine back because their body's new homeostasis to have nicotine around all the time, right? So one of the things they will have is a lot of anxiety, irritability. What do people's weight normally do when they stop smoking? Usually goes up because again, usually with smoking, usually sees a little bit of weight loss there. They can have depression, nausea, headache, all these things, right? So you're going to find that in order to fix that physical withdrawal, we try to replace it with the thing that they're addicted to, right? Just like when we're trying to get people off of opioids, what do we give them to wean them off of it? You're going to give them opioids, you give them methadone, right? So same principle here. You're trying to stave off those the nicotine withdrawal effects by giving them a replacement. Now, what are the different options we have here? We have a patch, right? So we can just do transdermal delivery of nicotine. What else we have? You have gums that they can be chewing. There's inhalers you can actually have. This is where like e-cigarettes or vaping pens and things like that can come into play here. Again, who's to say what the long-term effects of a lot of those e-cigarettes are going to be for those patients? Because again, a lot of times you're going to find that stuff is not well regulated at this point, and so we have no idea what else is in there. We don't know if that wonderful cotton candy smell that is being dissipated is going to cause cancer in the long run. Who knows, right? But to get them off cigarettes, it'll maybe help with the lung cancer aspect. Who can say? But this is one of those things where patients, you want to make sure they're not going to start smoking on top of this, because again, they can have nicotine toxicity, right? So they can develop things like seizures, developing arrhythmias, etc. So you got to be really careful and let them know, don't smoke on top of this, because again, they're just going to get that much more nicotine, and if they do it consistently, guess what? Now their actual dose they require to stay normal is not that much higher. Really not what we want to do for those patients. Now, this last one's called Varenicline or Chantix. Anyone ever heard of Chantix before? What have you heard about it? A lot of commercials for it. What do they talk about Chantix? What's the kind of interesting side effect? The dreams. Yes. What are you going to say?
I said like suicidal ideation. It's got like a metallic taste.
I was trying to go with the more like positive ones, but no, you're absolutely right. No, it would certainly get into that. So Chantix is kind of interesting because it actually works as a partial nicotinic receptor agonist. Okay, so that means that it's going to be able to activate those nicotinic receptors and just partially activate them. So even if the patient is still smoking, guess what? That nicotine or that Chantix is going to be binding to it tighter to the receptor than the nicotine can, and so it's going to basically prevent the nicotine from really kind of interacting. Okay, so the nice thing here is it's going to help to stave off some of those withdrawal symptoms, but they can still smoke on top of it, and it really doesn't have that much of more of an effect than you would see. So it's actually safe to do that. And in fact, what they'll recommend patients do is say a week or so before their quit date, go ahead and start the Chantix early, so that way they kind of get used to the drug effects, and then as they come off the cigarettes or the chew or whatever they're using, tobacco of choice, and then they continue that Chantix, so hopefully that will hold off the withdrawal symptoms, do about 12 weeks or so, come off, and then you kind of see where you're at, right? But again, because it's activating these nicotinic receptors partially, you end up seeing very strange side effects, and the big things are going to be the very vivid dreams they have. Patients talk about just the wildest dreams they've ever had were on Chantix, but to go along with that, some of these neuropsychiatric events like a black box warning for suicidal ideations, worsening depression, etc. Right? So you do have to be careful with that. Again, if the patient already has a history of depression, not well controlled, that might not be a very good drug for them, right? So, and then of course the COPD patients, make sure they get their yearly flu vaccine, and make sure they get their pneumococcal when appropriate. Make sure they're going to, because again, they're going to be immunocompromised, their lungs structurally are impaired, they can be more at risk for having infection, right? Any questions? Before I let you guys go. So you're, what, 50 minutes early? You're welcome.